Sound check, sound check. Hi folks, Professor Gulliford here. Let's do a screen share. Share computer sound and optimize the video so you get a nice clear picture. And we're going to call up the CSE review sheet, the clinical simulation review sheet, which is based upon our observations over about 5 years now of the trends in the exam, the topics which students see most often, the cases that you need to prepare for. This is updated December 23rd, 2019, and you could really call it the 2020 because this will be the last update for the year. Neuromuscular disorders figure prominently on the exam. You can certainly expect to see myasthenia gravis and maybe Guillain-Barré also. If it's a post-infectious case, that says Guillain-Barré. So that's a key fact that you need to know, is that usually the patient has an infection a couple weeks before the actual onset of Guillain-Barré. So make sure you know that. You may have both of these cases. Review the pathology. I strongly recommend the back section of the Kettering Study Guide. The Kettering Study Guide has a section called Pathology, and it is priceless. It's got all the key information that you need to know. Be sure to monitor these patients with tidal volume, MIP, and vital capacity. Know when to intervene. You don't have to wait for the patient to completely crash in order to intervene and ventilate them. In fact, you should not. If you see a trend that is disturbing, go ahead and intervene. Know all forms of treatment. Be sure you know about plasmapheresis. That's pulling the patient's blood out, removing the antibodies, and then putting it back in the patient, which is very helpful for neuromuscular problems. Burn patients, you're very likely to have a burn patient. Carboxyhemoglobin, be sure to measure that. If they inhaled smoke, they probably inhaled carbon monoxide. Assess of severity, initial treatment, long-term management, ventilator management. Draw blood gases in an area that's not burnt, just makes sense, but let me go ahead and mention that. And also an arterial line. If you're going to put an arterial line in, do it in an area that has not been burned. Hypothermia, there's a very specific hypothermia protocol. Warm blankets, IV fluids, of course, but the details are covered here at Medscape, and it's a very excellent article. I don't have time to go over the entire article with you here. That would take up our whole session. But at any rate, definitely take a look at that. You'll be receiving this CSE review sheet, and take a look at that article from Medscape. Key, warm blankets, warm IV fluids. MVA, motor vehicle accident, you're going to have paradoxical breathing, which means flail chest. So chest tubes, volume ventilation with PEEP. That's so important. If the patient has a flail chest, we must put them on a ventilator and use PEEP. Also review the proper functioning of chest drainage systems. That's well covered on the TMC review sheet. NICU, you'll have babies. I would say most students have 2 babies, maybe 3. Definitely review all your neonatal ventilation strategies, pressure control, jet, oscillator, all of those. Again, those are nicely covered on the TMC review sheet. You must know APGAR scoring in and out, so be sure to practice your APGAR scoring. You must know laryngoscope blades and ET tube sizes. Preemies will be 2.5 tube and a 0 Miller laryngoscope blade. And then your term infants will be 3.0 tube and a 1 Miller blade. Croup, review the treatment of croup. Definitely we're going to use racemic epinephrine. That's important to understand. And distinguishing it from epiglottitis. Let's talk about that a minute. Epiglottitis has a high fever. The kid comes in looking toxic and drooling, okay, and they cannot talk. The croup kid actually looks well. They sound terrible, but they look well and they don't have a high fever. They're not in distress. In epiglottitis, recognize that and take the patient to surgery. Sedate them and intubate them there. Do not take a look in the emergency room. If you take a look, you might cause the airway to completely close, and then we've got a real problem. Asthma. Expect adult asthmatic and pediatric asthmatic patients. Cool aerosol for asthma, not heated. Home treatment plan, be sure to include a peak flow meter and regular peak flow measurements. In the real world, not every patient has a peak flow meter, but every asthmatic should, all right, and know the green, yellow, and red zones. Let's go over that a little bit. The green zone is above 80% of the patient's personal best. That means they're good to go. Yellow is 80 down to 50. That means they need to get to an office, get to see their doctor, and get their treatment adjusted. Red, less than 50, straight to the emergency room. That right there is going to guide you well when you do your clinical simulation for asthmatics. Here are the National Asthma Prevention Guidelines. Excellent resource. There's the link to it right there. Cardiac arrhythmias. No troponin for sure. Troponin signals heart attack. It's important to know all of your cardiac rhythms, practice those things. It's pretty much the ACLS cardiac rhythms that you need to know. If you know all the ACLS cardiac rhythms, you're in good shape for that. Pharmacologic treatment of each rhythm, be sure you have studied that. Also, when to cardiovert, when to defibrillate. That's crucial, so let me talk about it in a minute. We defibrillate just two rhythms. They're called the shockable rhythms, and they are ventricular fibrillation and ventricular tachycardia without a pulse. Other rhythms get cardioverted, like maybe a supraventricular tachycardia or a VTAC with a pulse, but very important to know that for the test. COPD, know the ABGs to recognize it. That's going to be a high CO2 and a high bicarb to compensate. The chest x-ray, of course, long black lungs, hyper-resonant percussion, hyperlucency on the x-ray. PFT is going to show obstruction and also air trapping. Review your outpatient management, discharge planning, ventilatory management. You could very well have several COPD patients. CHF, know what you're looking for. The diagnosis, of course, you're going to have fine crackles. You're going to have an S3 heart sound. You're going to have pedal edema. Also know the ICU management, Swan-Ganz and hemodynamics. For example, you're going to have an elevated pulmonary capillary wedge pressure. Pay close attention to that. Elevated pulmonary capillary wedge pressure from fluid backing up into the lungs. Know the placement, the catheter, what the values mean. We're actually going to show you a hemodynamic circle coming up here in just a little bit, but definitely study CHF. You're likely to have a drug overdose, bag valve mask, ER management, ventilatory management. I might mention Narcan here, naloxone for reversal. You could possibly also have a benzodiazepine overdose, and that would be flumazenil for the reversal. Extubation, know how you determine readiness for extubation and what do you want to have on hand. Well, you want the full crash cart. And the reason for that is that as soon as you extubate, they could need re-intubation. So be prepared with a full crash cart, all the airway equipment, all the drugs, whenever you extubate. Football neck injury type patient, it could be any kind of neck injury, but let's just say a football neck injury. Careful assessment, CT scan for sure, so you understand what's going on with the spinal canal. Chest x-ray, neck x-ray, nasotracheal intubation to avoid extending the neck. Jaw thrust to avoid extending the neck. Now, in the real world, we don't always do that, but for the test, trust me, you want to do that. Know these meds very well. Albuterol, Alupent, oh my goodness, that's a very old bronchodilator. It's metaproterenol, Alupent, but you need to recognize it. Solumedrol, the steroid, acetylcysteine, Mucomyst, corticosteroids, of course, like prednisone, and propofol for sedation. The Kettering Pathology Review is extremely helpful. Use that, definitely use that. I think I already mentioned that, but it's the back section of the Kettering Study Guide. Trach performed today. Oh, look, trach performed today, and the nurse snipped off the pilot balloon. I've had a nurse do that. Rarely does an RT do it because we know what a hassle it is. But if you snip off the pilot balloon, there is a repair kit that will allow you to fix it. So don't panic and re-intubate the patient or anything like that. You can fix that pilot balloon with a little repair kit. NPPV, fixing oxygenation, fixing ventilation. Here's a key concept, folks. Fix ventilation first. Often the oxygenation problem gets fixed in the process. Better ventilation, the oxygenation improves on its own. Transposition of the great vessels, the egg-shaped heart. This is a congenital heart defect, and you definitely need to know about this. So review the pathology and treatment. Tetralogy of Fallot, the boot-shaped heart. review the pathology and treatment. These are all neonatal cases. Patent ductus arteriosus, know the preductal, postductal saturations. If there's a significant difference, which generally is thought to be 5%, if there's a significant difference between preductal and postductal, let's say right hand versus left foot, then that would be a patent ductus arteriosus. Coarctation of the aorta. Here is a great little summary from Mayo Clinic. Coarctation of the aorta. Know the diagnosis and treatment. Lung mass, understand the workup, the diagnosis, significance of cell types. Just a reminder, your small cell or oat cell is the worst type of lung cancer. The less invasive would be large cell or squamous cell. Pleural effusion, review the chest x-ray terminology, things like a meniscus sign, right? And opacity, possibly shifted trachea away. Transudate will be clear, exudate will be thick from infection or cancer, or could be bloody. Thoracentesis for the treatment and a possible chest tube. Now remember that chest tube for pleural effusion goes lower, down around the 5th to 7th intercostal space. Bronchiectasis, foul-smelling green sputum, that's going to be a code for this patient has bronchiectasis, so understand the pathology and treatment there. Sleep apnea, this is well covered on the TMC review sheet, but review the sleep studies, the diagnosis, the treatment. CPAP is sufficient for obstructive sleep apnea. It is not sufficient for central sleep apnea. There you need at least BiPAP, maybe a ventilator. Pulmonary embolism, you're likely to have a case on pulmonary embolism. Remember the D-dimer test, and I would recommend CT for the diagnosis. It could be a lung scan, but honestly, these days we've moved to CT for the diagnosis. The D-dimer test, as I mentioned, sudden onset. Post-traumatic is also a possibility. That could be like a femur fracture from a motor vehicle accident or a skiing accident or something like that. All right. Diabetes, be sure you recognize the ABG pattern, which is going to be acidosis with a low bicarb and a low CO2 to compensate. I say that again. It's going to be acidosis, low pH with a low bicarb and a low CO2 trying to compensate. Insulin, if it's severe, bicarb also. You may actually administer bicarb in these patients. Renal, you could have a renal case, and in that case, what we'd be dealing with is a high BUN, let's say in the 70s or 80s, normal's 20, and recognize the ABGs which accompany that. So that will be your renal case. PFTs, there's a great video series to help explain this in a ClinSim environment. I've provided the link for you here, so definitely take a look at this. Here's an interesting case. Patient scheduled for surgery but has a fever. How do you handle that? Well, of course, get a chest x-ray. We need to find out if they have pneumonia, determine source of the fever, and definitely reschedule the surgery. We shouldn't be taking people to surgery with a fever unless it's a true emergency surgery. Neonate with IRDS. These days, we usually call it RDS instead of IRDS, but review the pathology. Definitely chest x-ray and surfactant. You definitely want to administer surfactant. 100% of RDS kids improve with surfactant. The oscillator settings, neonatal ABGs, a little more acidic, a little higher CO2, a little lower, significantly lower O2. Pulmonary edema. Recognize the chest x-ray pattern, which is going to be fluffy infiltrates and a butterfly or bat wing pattern. Now, here's the thing. Lasix is what we really give at the hospital, but you might on the test see Bumex, which is bumetanide. Also, BiPAP recommended to drive the fluid back into the bloodstream. Hemodynamic also could come up in that. Now, here's the hemodynamic circle, and what we're looking for is where is the fluid or the pressure backing up into. Let's look at this hemodynamic circle. Let's say the problem's with the left heart, and I'm going to start at the left heart because that's where we have most of our trouble. Let's say the left heart is failing. Patient has had several heart attacks, let's say. Then that left heart pressure will back up into the lungs and raise the pulmonary capillary wedge pressure. So the wedge might be 18 or 20 instead of 8 or 10. Okay. Now let's say the lungs are the problem. Then you're going to back up pressure into the pulmonary arteries, raising pulmonary artery pressure. Maybe it's going to be 30 or 35. Let's say the right heart's the problem. Then the pressure would back up into the CVP, raising the CVP maybe to 10, 12, 15, something like that. And if the problem's in the body, meaning arterial constriction, then you would have high blood pressure. Instead of 120 over 80, it might be 150 over 100 or higher than that. So take a close look at that. Boy, this little circle helps you to figure out the hemodynamics. And I'm so thankful to whoever created this. I wish I knew who created it, but it has helped so many students. Chest x-rays, just go back over that whole section of the TMC review sheet. Recognize the main x-rays that you were likely to see, because what will happen is you'll be given an x-ray and then you need to recommend treatment. Knowing asthma medications by level of severity is so important, so please review. And here is the grid. This is for anybody over 5. Step 1, intermittent asthma, no daily treatment needed. Step 2, mild persistent. That's a low-dose inhaled glucosteroid, and then leukotriene modifier. Moderate persistent, low to medium inhaled glucosteroid, and a long-acting beta-2. Brovana comes to mind, and then other treatment options are listed there. Severe persistent, you go with everything. High-dose glucosteroid, sustained release theophylline, leukotriene modifier, long-acting beta-2, and an oral glucosteroid. So there you go. Now, I know you didn't learn it that fast, but go back over and review this several times before you take the test. Pulsus paradoxus is interesting. This is where the patient's blood pressure changes as they breathe. How would that happen? Well, if the patient is working so hard to breathe, as they exhale, their systolic pressure goes up. And as they inhale, then their pressure will go down. So in severe asthma, and that's the usual case that we see this in, pulsus paradoxus can happen. Might be a difference of as much as 40 or 50 between inspiration and expiration. This tells us the asthmatic's in real trouble if they have pulsus paradoxus. Know how to adjust the oscillator for ABGs. If you want to blow off more CO2, you will increase the amplitude and decrease the frequency. That is a very commonly misunderstood concept. You increase the amplitude but decrease the frequency, and that allows the piston to move further with each stroke. So that's quite different from typical ventilators. With Bunnell, the Bunnell jet ventilator, be sure you can know you only use it in conjunction with a conventional ventilator. It cannot be used alone. If you try to use it alone, you're going to head down a bad path. Know your ventilator waveforms. We've gone over this extensively on the TMC review sheet, but be sure you know all of those. For sure, the beak for overdistension. You need to decrease PIP or tidal volume. Flow starvation. That flow starvation pattern would really be an indication that you need to increase flow. Recognize a patient-triggered breath, a leak. Recognize the lower inflection point. So those are very, very important waveforms to review. So take a little time and look at those before you take the CSE. Shark fin pattern of bronchospasm is a famous waveform, of course. That tells us the patient's in bronchospasm. They're not just telling us they need a treatment, they really do. They're in bronchospasm because they have the shark fin. Hypoventilation, hyperventilation, decreased end-tidal CO2 from sedation or apnea, sudden loss of waveform, decreased end-tidal CO2. For CPR, you want to definitely have a 10 millimeter mercury waveform. If you don't, get somebody else doing the compressions because they're not working. And then there's ROSC, return of spontaneous circulation. Myasthenia gravis and Guillain-Barré, check those things every 2 hours. I think I forgot to mention that earlier. Nasotracheal intubation for a football injury, croup cases, racemic epinephrine and cool aerosol, viral, it's the steeple sign. You do not have a high fever. Oh, and just making sure you know that laryngotracheobronchitis is the official name for croup. Epiglottitis, you've got the high fever and drooling. They do not bark. The epiglottitis kid barks, but no barking. They cannot speak. To surgery, anesthesia, and intubate. Antibiotics, bacterial. The bug is Haemophilus influenza. You might need to know that. Asthma exacerbation, 80% above personal best, good to go. 50 to 80, office visit. Less than 50, straight to the ER. Now, there's actually quite a bit of home care included on the CSE exam, so be sure you know about disinfection. 1 part distilled white vinegar, 2 parts water, soak for 20 minutes, rinse and air dry. Be sure to provide portable oxygen if the patient is mobile. If they're up and moving around, going shopping or going to work or whatever, then make sure that they have a portable mechanism. Just CPAP for obstructive sleep apnea, NPPV for central sleep apnea. Pathology section, I guess I've had that on there a couple times now, sorry, but it's so important. Review the pathology section of the Kettering Study Guide. Oh, here are chest x-ray descriptions. Now, they might give you the actual chest x-ray, but very likely they're just going to describe it. Hyperlucency would be black, like pneumothorax, or maybe like severe emphysema. Opacity, white, like pleural effusion. Meniscus sign, pleural effusion. Consolidation specifically means pneumonia. Butterfly or bat wing, pulmonary edema. Reticulogranular, the whiteout is ARDS. So those, I think if you know all of those, you'll be pretty well off. PFTs, be sure you know the CBABE diseases. That's cystic fibrosis, bronchitis, asthma, bronchiectasis, and emphysema. If the FEV1 to FVC is less than 70, that is obstruction. Restriction is a TLC. If you don't have TLC, then use FVC less than 80. Lots of troubleshooting. You should prepare for every kind of troubleshooting situation, like a high pressure alarm, a low minute ventilation alarm. What would you do first? One thing you definitely want to do is check tube position first. If the tube has slipped out or it's down the right main stem, that could be the whole problem. Okay, careful, the ABG may show better PaO2, but the FiO2 has been raised a lot, so the patient's not better. That is so important. Let's say the patient's PaO2 has gone up from 40 to 70. Well, we're happy about that, but if we had to go to 100% oxygen to make that happen, that's not good at all. ACLS protocols, honestly, I hope that you're ACLS certified by now. If you're not, go get ACLS certified. But if not, go ahead and study it at acls.net. Know all of the protocols. They're going to be heavily covered on the test. Narcotic overdose, you must know to use naloxone to reverse. That's my puppy making a little growling sound in the background here. You must know the protocols for home oxygen and infection control. Flail chest, you must intubate the patient and use PEEP. Flail chest, must intubate and use PEEP. Oh, pneumothorax, this is so important. At the hospital, you may see a chest tube put in immediately for a pneumothorax, but for the test, we do needle decompression first and then place a chest tube. The needle goes at the second intercostal space, mid-clavicular line. So I hope that's helpful. You're going to have 22 clinical simulation cases. 20 of those are graded, and the other 2 are in beta testing. They're using you for a guinea pig on that. Students tell me they have plenty of time, so do not feel rushed. In fact, I cannot remember a single student that ran out of time. So that should really tell you something, that you've got plenty of time to think through these things. Hope that was helpful. I will send you the updated CSE review sheet, and if you don't have it, just email me at Daryl.Gulliford. That's DERYL.GULLIFORD @independence.edu, and I will get it to you right away. Wishing you success on your CSE exam.